This is Heart Rhythm TV. My name is Janet Hahn, and I am so happy to welcome my friend Nishaki Mehta. She is a cardiac electrophysiologist, associate professor of medicine at the William and Beaumont Hospital. So welcome, Nishaki. How are you?
Thank you so much. I'm excited to be here.
It's great. I just saw you. I just saw you at FHRS, so I feel like I literally just saw you like yesterday. So
not too long ago. Yeah.
I know. So I wanted to invite you on the show today because you did this great trial that I feel like I needed to sort of share with the world a little bit, and it was called the Redefine trial. And I'm not going to get into it because I want you to talk about it, but it really was about an astounding radiation reduction within the EP lab. And I know that we're all super interested about radiation reduction in the EP lab because I think, we've done a great job reducing radiation with ablations, but really this study was focusing on radiation reduction with devices, which I think now is the brunt of where EP people get our radiation, right?
Absolutely. I think that's really the next frontier to break down in terms of radiation reduction. And most folks think interventionalists get more radiation, but it's really the inverse square law. We're standing right in front of the tube. So we're getting 4 times as much radiation for the same amount of time than my interventional friends who are a foot away working on the arm.
No, absolutely. So let's, cue up your slides here. So you want to just talk about like, what was your study called and what was it? What was the background behind this study?
Sure. So the study is called the Redefine trial, and it's a prospective randomized evaluation of a new technology that is integrated in the X-ray tube. And the idea was to investigate whether this could reduce radiation in device procedures, specifically device procedures, given that most ablation procedures are now 0 to no fluoro.
Okay, and so I was really super interested in this trial because I was trained as a ophthalmologist once upon a time, and so I know you're like, what? So I know that your study was based on how the human eyes and human brain see. So you want to talk through that a little bit?
Yeah, I think this is the coolest part about the study that attracted me to this technology. So when I'm looking at you, Dr. Hunt, I'm focused on your face. My center of gaze accounts for a 5% area of high sharp contrast definition. And this is the area where the light is hitting the fovea at the back of the retina. The background is constructed with 95% low resolution pixels. So all we see is really 5% sharp, high quality image with a peripheral low resolution background. So given that finding, why do we blast ourselves with 100% high sharp contrast imaging in the X-ray field? Why not use the same nature's principle when we look at an X-ray image or a cine image?
Yeah, no, I fully understand that. And that seems like what you're saying is absolutely we need that sort of tiny field of view, 10, 25% right in the center, right? And then the rest peripheral. We see things and we see them moving and we see the gist of it, but we don't need to really focus on that. Am I right?
Exactly.
Okay, so let's look at the technology behind what that is. Okay, so you want to talk about this a little bit?
Yes, it's actually a clever and simple idea. These are moving plates that create a window. So you can see how the window, the black area in the center, is changing its shape based on how the collimators are coming in and out. But unlike a regular collimator that completely, dulls out the background, these plates are made of semi-transparent titanium construction. So they allow for some X-ray to go through, but block a majority of the X-ray. Whereas the central window that we see changing dimensions based on the vector of the plates, that allows an unfiltered photon beam to come through and create a very high definition image.
Yeah, and that almost seems to me analogous to how the iris of the eye works. Like it's almost like an aperture in some way, right? You have like, depending on how much light you want in or how much of the image you want in, your iris gets big or small to sort of accommodate for that. So knowing that now, how did you use this in your study? So let's talk about your study protocol.
So given that information, we were fortunate to have this technology installed in one of our X-ray tubes. And we decided that the focus of this would be really where we get the brunt of the radiation in device procedures. given those two factors, we did a 2-to-1 randomization for simple versus complex procedures. And in each cohort, we did a 1-to-1 randomization to control rad therapy on or off. So all procedures were done in the same room. And in folks who had the control rad option, the electrophysiologist was given the option to operate this. And in the others, it was simply turned off.
Okay, got it.
We were very cautious with our exclusion criteria. We avoided concomitant AV node ablation, lead extraction or revision procedures, and leadless pacemakers. So we really wanted to capture like 95% of device implants.
Okay, that totally makes sense. Now, we're going to sort of see it in action, right? So this is actually a picture of the fluoro and how you see it using this device, right? So you want to describe this a little bit?
Yeah, sure. So this is actually, so we were putting in we were doing conduction system pacing. It's one of my partner's procedures. And there are a few highlights on this slide. The first one is the white box. So the white box is really what we call the region of interest. That's what my partner drew out on the tablet that's attached to the sterile field. And you can move that box around, but that box represents the window that's created by those moving plates. So that box has an no unrestricted high resolution image. And what's really easy to see here is the TAVR valve. The part of the TAVR valve that's within the box is high definition versus the one that's outside the box is more blurred, but you can still make it out, as you said earlier. So that kind of gives you an idea of what's sharp versus low resolution imaging. The conduction system lead, you can see it with very high definition, but you see a catheter in the RV apex, which is blurred, but you can still see where it is. So you know your whereabouts. You have a general idea of what's going on in the periphery, where you can move the box if you're interested to relocate your center of gaze to another area of interest. And then the other cool thing about this is at the very bottom of the slide, you see a depth reduction. So every time you make the window small or large, or you move it around, you get a real-time idea of the reduction of depth.
Oh, that's outstanding. And again, I'm really astounded. You really are able to still see the peripherally quite well. I think, when people think about this, they think, oh gosh, I'm not gonna be able to see sort of the lay of the land, like we try to say, right? But you really can still see all your catheters and really where they are to more of a degree than I thought that you would be able to see based on those sort of sliding plates, right? So I think this is great. So I would love to see now your results. So, because this is really the most exciting part. So go ahead and go through this.
So, truly like a randomized trial, there was really no difference in baseline characteristics. But what I'd like to point out to you, Janet, is the procedure time. So for this trial, we did not really have a roll-in period. People just went ahead and started using the technology. And it really didn't cost us in terms of procedure time. It was equivalent in both arms. And the other thing I was particularly keen on was complications. And there was really no difference in the complication rates in this procedure. And here you can see we did actually more right-sided implants than we traditionally do. And it really didn't matter.
No, absolutely. And then this is probably the best slide, the take-home slide, right?
I think so. I think this really emphasizes how this technology not only helps me as the primary operator with a 60% reduction in radiation, it also helps my surgical assist with secondary operators benefiting from radiation reduction, and it helps our patients. So there's a 53% reduction in the dose to what the patients receive. But to what I was alluding to earlier, this technology doesn't prohibit other technologies from being used. So in the first slide that we had shown with the conduction system pacing lead, I can still bring in my regular collimators.
Yep.
So I can keep adding and adding and adding, in the quest of coming to as low radiation goals as possible.
Yeah, and this really is about layered protection, right? This is just yet one more strategy. So on top of the 60 and 70 and 50% reduction that you have listed on this slide, on top of that is your lead, all your shields, the collimators, like you said. So this is really truly layered protection and layered radiation reduction. So it's probably more than what you're seeing here on this slide.
Absolutely, because in the study we couldn't use the rat pads and the other stuff to keep things homogeneous, but it's only going to get better.
Yeah, so this is great. I feel like again, this is where all of the radiation that we're getting it in our big device procedure. So one more slide to go through here. You want to talk about this one?
Yes. So in this, we kind of broke it down by procedure type, and not surprisingly, we found that the radiation reduction was primarily driven by complex procedures with longer procedure times, and that drove majority of the effect that we saw in this trial.
No surprise.
I would like to also say that we are very fortunate here. We have two ways to determine radiation. One is the traditional standard aluminum oxide patch that calculates cumulative radiation for an operator. But we also have RaySafe, which is a real-time radiation badge. Mm-hmm. So I clip it on, I do the case, I come back and I flash it in front of the sensor, and I get a real-time radiation for the case. So it's very encouraging to see when you get very little radiation by using all the technologies, and it gives us good feedback and encourages good behavior in the lab.
No, absolutely. So I think, gosh, this study is really outstanding. I'm always so happy to see more work towards decreasing radiation exposure. I think when I started, there was none of doing sort of fluoroless ablations, and now look where we are, right? And so I think, again, this is sort of the final frontier for us for trying to get that radiation exposure to be as close as to zero as possible. And I think this will really help encourage those who are reluctant to go into EP because of the thought of, oh gosh, so much radiation in the EP field, right? Especially the women that want to go into this field. I think this could be a boon to that for sure.
Absolutely. And we're doing a side study, and we're still not, we're finding early signals that shorter folks get more radiation.
Yes, it's not me.
So, I feel like little women like you and me, I mean, this is huge. And, for our staff, right?
Oh, absolutely. No, this is
day in, day out.
Yeah, this is like team, right? The whole team gets less radiation reduction, and including the patient, who's really the most important part of the team. So Dr. Mehta, Nishaki, my friend, thank you so much for coming on the show and talking about this great study. I wish you great success in this area. So keep on keeping on. And for those of you watching out there today, thanks for watching, and make sure you hit that like and subscribe button to make ssure that you keep watching HRS TV for the latest and greatest in EP news and science.
Thank you so much, Dr.